Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of Kearns-Sayre Syndrome, prepared for general pediatricians. Kearns-Sayre Syndrome is a rare mitochondrial disorder that affects the eyes, the heart, and many other organ systems. Across 12 carefully crafted clinical cases, we will work through clinical presentation, characteristic eye findings, retinopathy, the genetic basis, heteroplasmy and threshold effects, diagnostic criteria, muscle biopsy interpretation, cerebrospinal fluid analysis, differential diagnoses, cardiac management, mitochondrial supportive therapy, and long-term prognosis. Let us begin. Case 1. A 14-year-old boy presents with progressive drooping of both upper eyelids. Over 18 months, he developed difficulty with upward and lateral gaze. He reports poor night vision and has had 2 recent fainting episodes. On examination, there is drooping of both eyelids, weakness of the muscles that move the eyes, pigmentary changes in the retina, and complete heart block on the electrocardiogram. What is the most likely diagnosis? Option A, fainting, heart block, and night blindness. Option B, eyelid drooping, cataracts, and sensory neural hearing loss. Option C, chronic progressive external ophthalmoplegia, pigmentary retinopathy with onset before age 20. Option B, cerebellar incoordination, elevated cerebrospinal fluid protein, and proximal muscle weakness. The correct answer is option C. This describes the classic essential triad of Kearns-Sayre syndrome. The triad consists of 3 elements. First, chronic progressive external ophthalmoplegia, which presents as drooping of both eyelids, together with limitation of eye movements. Second, pigmentary retinopathy. Third, onset before 20 years of age. To make the diagnosis, at least one additional criterion is also required, such as a cardiac conduction defect like heart block, cerebellar incoordination, or cerebrospinal fluid protein above 100 milligrams per deciliter. This patient shows the complete triad, together with complete heart block, so he meets the diagnostic requirements clearly. Case 2. A 14-year-old boy presents with drooping of both eyelids and pigmentary retinopathy on fundoscopy, described as a salt and pepper appearance, with onset before 20 years of age. The electrocardiogram reveals conduction defects. Which feature is most characteristic of Kearns-Sayre syndrome? Option A, head tilt with variable eyelid drooping and complete ophthalmoplegia, often mistaken for myasthenia. Option B, cardiac conduction block with progressive atrioventricular block, potentially leading to fainting and sudden death. Option C, acute vision loss and eye movement weakness with preceding painful eye movements. Option D, intermittent eyelid drooping that worsens with fatigue, improving after sleep or an ice pack. The correct answer is option A. Note that the slide labels the correct answer as A, while the body text describes the cardiac conduction block. The truly characteristic ophthalmologic feature here is the compensatory head posture. Patients adopt a chin-up head position, which is a compensatory mechanism for severe ophthalmoplegia and eyelid drooping. The eyelid drooping is bilateral, with reduced levator muscle function, and it is not aponeurotic in origin. Importantly, double vision is typically absent because the eye muscle weakness is symmetrical and slowly progressive. This contrasts with myasthenia gravis, where symptoms are sudden, fluctuating, and episodic. The salt and pepper pigmentary retinopathy remains a hallmark finding. Case 3. A 16-year-old male with known Kearns-Sayre syndrome attends for routine follow-up. His visual acuity is 20/40. The anterior segment of the eye is normal. Dilated fundus examination reveals retinal pigment granularity with diffuse stippling. Regarding the visual prognosis, which statement is most accurate? Option A, bilateral blindness by age 30. Option B, preserved visual acuity despite the retinopathy. Option C, rapid progression to retinal atrophy. Option D, cataract-related vision loss. The correct answer is option B. Patients with Kearns-Sayre syndrome usually maintain relatively good visual acuity at the time of diagnosis, despite visible pigmentary changes in the retina. The retinal changes progress slowly over years to decades, not over months. Optical coherence tomography may reveal hyperreflective deposits above the retinal pigment epithelium. Although central macular involvement can develop after decades and gradually reduce vision, severe early blindness is not typical. The retinal findings are an important clinical marker that points toward the underlying mitochondrial disorder, even when vision itself remains functional. Case 4. A 12-year-old female presents with progressive drooping of both eyelids, weakness of the eye muscles, and pigmentary retinopathy. Molecular analysis reveals a 4.9 kilobase large-scale deletion in the mitochondrial DNA. Her family members are all asymptomatic. Which statement best explains the genetic basis of her condition? Option A, autosomal dominant inheritance. Option B, sporadic large-scale mitochondrial DNA deletions. Option C, X-linked recessive transmission. Option D, trinucleotide repeat expansion. The correct answer is option B. Kearns-Sayre syndrome is caused by sporadic large-scale deletions of mitochondrial DNA, typically ranging from 1.1 to 10 kilobases in size. A common deletion of about 4.9 kilobases is found in more than one-third of patients. These deletions arise spontaneously during egg cell formation or in the early embryo, which is why the condition is usually not inherited and the family is asymptomatic. The deletion impairs oxidative phosphorylation and affects mitochondrial transfer RNAs, which reduces the cell's ability to produce energy. This explains the multi-system involvement seen in tissues with high energy demand, such as muscle, nerve, and the retina. Case 5. A 14-year-old with multi-system involvement, including ophthalmoplegia, retinopathy, heart block, and incoordination, undergoes testing. Cerebrospinal fluid protein is 125 milligrams per deciliter, which is elevated. Blood lactate is 4.8 millimoles per liter, also elevated. A muscle biopsy shows a 75% deletion load, while a blood sample shows only 15%. Which concept best explains this pattern? Option A, anticipation with trinucleotide repeats. Option B, heteroplasmy with tissue-specific distribution and threshold effects. Option C, genomic imprinting. Option D, loss of heterozygosity. The correct answer is option B. Heteroplasmy describes the coexistence of both normal and mutant mitochondrial DNA within the same cell. Disease occurs only when the mutation load exceeds a tissue-specific threshold, which is roughly 60 to 65% in muscle. The mutant mitochondrial DNA is not distributed evenly across the body. Post-mitotic tissues, such as muscle and retina, tend to accumulate higher mutation loads over time. This is exactly why the muscle biopsy showed a high 75% deletion load, while the blood test showed only 15% and may even appear negative. This is a critical point. A normal blood test does not exclude a mitochondrial disorder, and muscle remains the preferred tissue for diagnosis. Case 6. A 17-year-old male presents with a 3-year history of progressive bilateral eyelid drooping and chronic progressive external ophthalmoplegia. Fundoscopic examination confirms pigmentary retinopathy. Further evaluation reveals cerebellar incoordination and a cerebrospinal fluid protein of 120 milligrams per deciliter.